Dr. Clark. To close out our session, Dr. Erin Clark is here, and she is an Associate Professor of Obstetrics and Gynecology at the University of Utah. Today she's going to present on healthy birth spacing and the role of both the prenatal contraceptive plan and the postpartum birth plan. Thank you for being here.
Thanks. It's a pleasure to be here today as the closeout speaker for this session. I wish I would have been able to join the previous 5. They sound like they were amazing. So we're gonna concentrate on a little bit of a different topic today, and that's how things like birth spacing can affect obstetric outcomes. So my background is that I'm a maternal fetal medicine physician. I specialize in pregnancy complications like preterm birth, and I see women who've had complicated pregnancies in the past or who have complicated pregnancies now, and I see them in the form of preconception consultations, meaning they know they've had a complication in the past, and I'm seeing them before they're getting pregnant so we can make a plan, or I'm seeing them after they've had a complicated pregnancy, and in fact, you know, postpartum is also preconception since many women go on to have another pregnancy. And I also take care of them during their high-risk pregnancies. And my home base is University of Utah Healthcare. I don't have any conflicts of interest to disclose. Our learning objectives for today are that at the end of this, you should be able to describe the basic association between birth spacing and some of the most common pregnancy outcomes. That you're going to be able to discuss how a prenatal contraceptive plan influences contraceptive uptake in the postpartum period. And we're going to discuss how a postnatal birth plan might affect obstetric outcomes in the next pregnancy. So we're going to start with the definition. This is casual, by the way, so if I can see you on the screen or if you're unmuted, you can feel free to interrupt with questions. And if not, we'll do some Q&A at the end. Interpregnancy interval is also referred to as birth to pregnancy interval, so different than delivery to delivery. This is from the time you have a baby until you're pregnant with your next child. And it has been associated with birth outcomes. Both short interpregnancy interval and long interpregnancy interval have been associated with an increased risk of pregnancy complications. But as we go through this data, you'll see that most of the risk is when you have too short of an interpregnancy interval. A short interpregnancy interval has variable definitions in the literature, but one commonly used definition is an interval from delivery to the next pregnancy of less than 18 months. So a question to ponder is, what percentage of U.S. women do you think have a short interpregnancy interval? And the percentages that are options are 10%, 30%, 50%, and 80%. So just think in your mind what you think the proportion would be. In actuality, it's about 30% of U.S. women who have a short interpregnancy interval of less than 18 months. A long interpregnancy interval is typically defined as a duration longer than 60 months in between pregnancies. There's some ideas about why interpregnancy interval is related to obstetric outcomes. If you think about, okay, how could having a baby, one rapidly right after another, have an impact on the outcome of that next pregnancy? A few things come to mind. One is what we call the maternal depletion hypothesis, and that's that, you know, you have a given amount of vitamins, minerals, and nutrients in your system, and that if you get pregnant again rapidly, perhaps those have waned and you're in a less healthy state to get pregnant the next time because you haven't given yourself enough time to sort of replete nutritionally. There's some data in the literature that suggests, for example, that after a pregnancy, you have lower levels of things like folic acid and iron, and perhaps that sets you up to have a more complicated pregnancy if you don't give yourself enough time to replenish those supplies. I think an intriguing hypothesis for us as high-risk physicians is this idea of residual inflammation of the genital tract. We know that inflammation seems to be a key driver down the path to preterm birth, either because you break your water early or because you actually go into labor. And there's some thought that that process, once started, takes some time to resolve. So if you have a preterm birth and you've got some inflammation, maybe you're especially set up then to sort of go down that inflammatory preterm birth pathway again. And even if you don't have an abnormal pregnancy, perhaps there's enough inflammation there that it just adversely influences your next pregnancy. And then there is some data, too, about sort of this incomplete healing idea. If you have a C-section, you have a scar on the lower part of your uterus, and you get pregnant and put a baby in there sooner than maybe is optimal, you can see that that scar might not be well healed, it might not be as strong, and you might be at increased risk for things like uterine rupture if you tried to have a vaginal birth again in a relatively short interval. So those are sort of the three key ideas about why short interpregnancy interval might influence pregnancy outcomes. It's certainly an area that's poorly understood, and there's lots of confounders when you try and think about these relationships. Socioeconomic confounders, breastfeeding confounders. It makes figuring out the effect of interpregnancy interval definitely more complicated. When we think about why long interpregnancy interval is associated with adverse outcomes, there's a whole bunch of sort of wacko ideas out there about why this might be the case. Some people have said, well, maybe there's something advantageous about pregnancy, like more uterine blood flow, that if you go too far out from that, that advantageous effect goes away. I don't know. Some of these seem kind of far-fetched. But one of the things that I find most intriguing about this idea is that women who take longer to get pregnant, sounds like we have someone who's not on mute on the call. If you could mute yourself, that would be perfect. All right, so interpregnancy interval. Long interpregnancy interval often occurs when people have, less optimal fertility, subfertility, or those people who are just not as healthy. If you think about it, people who have obesity, diabetes, chronic autoimmune disease, these people tend to be a less fertile, healthy, robust bunch, and it can be longer in between their pregnancies. And so it might be that it's not the interval itself, but it's the marker of who has a longer interval that's associated with the adverse outcomes. This might, in fact, be the reason why, contrary to what we've thought for many years, if you look at women who had a miscarriage, and you look at how long it takes them to get pregnant and what their outcomes of that pregnancy are, we used to tell people, gosh, you got to wait a certain amount of time before you get pregnant so that you have the healthiest chance of a pregnancy. Well, when they actually look at it and track people really carefully, the people who get pregnant fastest after a miscarriage actually have lower risks. And it's probably because those people who get pregnant fast are healthier and more fertile and at lower risk to begin with, right? So that's the idea behind that association. So here's some of the things that I want you to think about and know coming out of this discussion with regard to interpregnancy interval and how it affects pregnancy outcomes. So first, small for gestational age. This means, it's sort of equivalent to intrauterine growth restriction. You have a baby that is less than the 10th percentile, smaller than you would expect, and short interpregnancy interval definitely seems to increase the risk of that. That's partly why people have been so enamored of this sort of nutritional depletion hypothesis. Preterm premature rupture of membranes and preterm birth. So that, again, remember, think about the inflammatory pathway and the idea that maybe that is why you have, why short interpregnancy interval leads to more early deliveries. Congenital abnormalities are also increased. And people will sort of reference back to that idea of, well, maybe your folate's too low or you have some other nutritional deficiency that's increasing the chance of a congenital anomaly. There's other things like even autism, and there's some reports even of things like schizophrenia being increased when you have a short interval. We talked about miscarriage being the one that sort of stands out as the effect size in the other direction. Most current literature suggests that there's either no effect when you have a short interpregnancy interval, or maybe your risk is even lower. And then the two final items on the list are stillbirth and neonatal death. So adverse pregnancy outcomes of the highest magnitude seem to be increased when that interpregnancy interval is too short. And most of these arrows here are looking, the biggest effect size is when your interpregnancy interval is 6 months or less. The effect is still there between 6 and 12 months and 12 and 18 months. It's just that that effect goes down. There's less known about these associations when it comes to long interpregnancy interval, but long interpregnancy interval does seem to be associated with an increased risk of congenital anomalies, maybe for some of the reasons that we talked about. If we look at maternally focused sort of outcomes, maternal anemia is higher with short interpregnancy interval, which makes sense. This is a woman who has had a pregnancy and maybe even had some breastfeeding and now is more nutritionally depleted. Preeclampsia goes up with short interpregnancy interval, as does uterine rupture, maybe because of that recovery time, scar strength issue that we talked about. And then maternal death might actually go up in some studies. So for moms and for babies, a particularly short interpregnancy interval seems to have a very real and very significant effect on outcomes. So one of the things we're going to highlight today is preterm birth, because preterm birth is one of the most common adverse obstetrical outcomes and is tightly related to pregnancy interval. So if you have an interpregnancy interval of less than 6 months, the risk of preterm birth in a variety of studies goes up by about 40 to 70%. So your odds ratios are between 1.4 and 1.7, and that's pretty consistent in the literature. And this is among women who had a previously uncomplicated term birth. So they are proven reproducers who then just got pregnant too fast, and their risk of delivering too early goes up. If you look at just women who have a spontaneous preterm birth as that second birth, the risk may be even higher. In other words, if you had an uncomplicated term birth and you just look at what are your chances of going into labor too early or rupturing your membranes too early, that risk is especially high. And that's why we sort of think there's something that happens in the reproductive tract, maybe inflammation, that if you get pregnant too soon sort of drives you down that preterm birth pathway with much greater frequency than you would have gone on down had you given yourself more time. And again, we see a significant but a lesser effect for longer birth intervals, but intervals that are less than 18 months. And if you have a preterm birth to begin with, you can see that you may have even a higher risk, and studies have shown that you have a higher risk if you have a preterm birth and a short interpregnancy interval. And to us, that's really sort of a recipe for implications of obstetrical badness. Can everybody go on mute again? Thanks. So yeah, this obstetrical badness recipe, one of my most concerning patients coming to clinic is a patient who had a very early preterm birth, who now has an unplanned, unexpected, short interval repeat pregnancy. 24-weeker, pregnant 3 months later is one of the scariest consults that we do because their chances of a repeat poor obstetrical outcome is very high. So what do we recommend to people when we're talking about birth interval? So regardless of what their previous pregnancies looked like, even if they were uncomplicated, the summary is that the best data suggests that interpregnancy interval of more than 18 months and probably less than 5 years is optimal. Interpregnancy interval of over 18 months is especially critical in women with pregnancy complications like a preceding preterm delivery. And so that's how we counsel everyone. Now, are there exceptions to an 18-month interval? Sure. Can you think of some of them? Can we make this interactive?
Sure, if they want to unmute themselves. Or
can you think of a reason why someone, like normally we would say 18 months, absolutely. Can you think of like a clinical scenario where we would sort of skirt around that and say, well, maybe actually getting pregnant a little earlier is okay? Yeah, that's a good one. So advanced maternal age. Say you've got a woman who's 42. She may have very little natural fertility left. She just had, say, a 36-week delivery. She really wants another natural-born child without having to go through reproductive assistance, if at all possible. Well, we talk to that woman about risk and benefit and say, you may be a little higher risk for an adverse outcome if we don't wait, but if we wait, you may not get pregnant at all. And so while these are sort of black and white recommendations, it's a good example of how you have to tailor to the specific situation. I can think of another one, stillbirth or a neonatal death. In those situations, we are very clear with patients, that waiting, assuming there's nothing else that would affect their fertility, that waiting is their best option. But sometimes parents are so motivated to get pregnant again in the short interval, they are heartbroken. Some of them are not ready, but some of them are more than ready and feel like that's an important part of the healing process. And so it's often a negotiation between what's best for you as parents and family and what's best in terms of medical decision making. And sometimes we come to a comfortable middle ground, like let's try a year. Let's see if we can get a year, get you recovered from this previous C-section, and then we'll let you try and get pregnant again. So there are some exceptions. There's very little justification for being absolutely dogmatic when it comes to obstetrics. You kind of take the key principles and then an individual patient situation and you try and make the best recommendation that you can. So preterm birth, we're going to highlight this for a minute because it is one of the issues that's going to demonstrate some of the concepts with regard to antenatal contraception plan and postpartum birth plan that we're trying to make today. It's important that you understand a little bit about preterm birth to have this discussion. So on average, about 1 in 10 U.S. births are preterm. This is actually higher than other developed nations. Preterm birth is defined as birth that's more than 3 weeks before the due date. So if 40 weeks is your due date, preterm birth is something that is earlier than 37 weeks gestation. So up to 36 and 6 is considered preterm. Less than 32 weeks is considered very early preterm. Preterm birth is a leading cause of infant mortality and long-term morbidity in the U.S. and worldwide, and it costs us, quote, gobs of money because estimates are hard to make. Our last best sort of economic analysis was about 10 years ago, and it suggested that the U.S. cost was over $26 billion a year, and I guarantee it's a lot higher now. And this is an unsolved problem, so we have a paucity of intervention and prevention strategies for preterm birth. Because it's a huge problem and we only have a few strategies, it means that we want to use them as consistently and as ubiquitously as we possibly can. So how do we predict who's going to deliver early? Oh, it's a hard game. So if it's the first birth, the first pregnancy, it's virtually impossible to determine who's going to deliver early. Now, family history helps. It helps a little bit. If you have multiple family members that delivered early, it piques my interest. And there's a lot of scientists around the world trying to work on biochemical tests that might predict who is actually going to go into preterm labor. But we have not solved that problem yet. So right now, predicting first preterm birth is virtually impossible. And the biggest risk factor for preterm birth remains having had one before. So history, personal history, is really the strongest risk factor. After the first preterm birth, optimizing interpregnancy interval really becomes a key strategy to reduce the risk of recurrent preterm birth. We have very little, we said, in terms of ways to prevent another one. So once we recognize a woman is at high risk for having had one, we try to prevent the next one with strategies like making sure that they don't get pregnant too early. And how do we influence interpregnancy interval? Well, there's two key strategies that I can see in the literature and in personal experience that seem to really help. One is a prenatal contraceptive plan, and the second is a postpartum birth plan. And if you think about these terms for a minute, they don't make any sense at all, right, at first blush. Why would you be making a contraception plan when someone's already pregnant? Why would you be making a birth plan when someone's just had a baby? But in fact, these are brilliant ideas because it's preparatory. So it allows you to anticipate issues, to make a plan beforehand, and there's some good data that is suggesting that a plan in advance seems to influence human action. I think we could probably draw some examples from our everyday lives, right? If I say I'm going to go on this diet on this day and I tell everybody, I'm probably more likely to do it than if I just keep it as an internal thing. Humans are humans. So prenatal contraceptive plan. So if we think about talking to women about contraception before they deliver, antenatal counseling, our cumulative experience suggests that if we do that, that they are more likely, perhaps more likely to show up for postpartum care, but more likely to have effective contraception in the postpartum period. There was a randomized controlled trial done here. The lead author was Dr. Leah Torres that looked at contraceptive counseling for women who had had preterm birth. And when they randomized people to like really good counseling about contraception and its impact on pregnancy outcomes and their options versus just our sort of standard 5 o'clock in the morning, hey, would you like some contraception, what do you plan to do talk, and they looked at women who ended up getting long-acting reversible contraception, the biggest predictor of who ended up getting it was who had an antenatal plan in place, not who got the counseling, although the counseling was significantly associated with your chance of getting long-acting reversible contraception. It was really the people who had a plan in place. If you had a plan, that counseling didn't matter, in other words. So it was the strongest predictor of who followed through and actually got contraceptive care. This is a big problem for us, you know. Not everybody shows up for postpartum care. Getting people to sort of commit to a plan and follow through, human behavior being what it is one of our biggest challenges. So we've tried to create some tools that I'll share with you in our electronic medical record that sort of prompt us to do this sort of discussion and counseling and decision making. This is a fancier version than you need. You know, this can be just a note on a paper chart that you have discussed the contraceptive plan and this is what you're going to do. But we built it in 2 ways, since we were stuck with an EMR. So one, we have a pregnancy checklist that we use. I don't think I have a pointer on this to kind of guide you. Oh, there it is. So you can see the pregnancy checklist. This is a tiny arrow, so watch the gnat. But it goes first trimester, second trimester, early third, and late third trimester. And under the late third trimester category, there's a variety of items that we feel like it's important to discuss. Group B strep screening, there it is, contraceptive counseling, and then a myriad of other things that we feel like we just need to mention and talk about in the third trimester. And this ensures that it actually is done. So you can see that these were added the day she started her pregnancy care, and I actually completed them on this patient on October 3rd and talked to her about all these items. And how we document that we actually had this discussion and what we decided on is another section that we title Contraceptive Plan. And you can see that this plan was made at 11:56 last night. Curious. It's a strange time to be counseling patients. So the method that we chose was IUD. We decided she was not going to get it before hospital discharge as immediate postpartum contraception. She chose postpartum follow-up, and then we clarified in the box. And sometimes in this, because this is a little bit redundant what's written in here now, we say why they picked the method they did and why they didn't pick another method, just to jog our memory. Like she can't have estrogen, she has a history of blood clot, she chooses Mirena IUD. And that plan, it's a beautiful thing. I mean, there are some pros and cons to electronic medical record, but this allows that plan to then populate the notes going forward. So you don't have to go back to that plan to see what someone wanted to do. When they're admitted on labor and delivery, it flows into their admission H&P and it says this is their contraceptive plan. The notes that they have for their postpartum stay, it flows into those postpartum notes. So it's imminently visible to everyone who's taking care of this patient. It's also visible when they come in for their postpartum visit so that we don't have to have the conversation again. And we really feel like this optimizes the chances that a prenatal contraceptive plan will actually become a postnatal contraceptive reality, which is the end-all goal. So we're going to talk about postpartum birth plan now. So we talked about prenatal contraceptive plan, what it looks like, what it might do for us, and we're going to move on to postpartum birth plan. So this is really a discussion about what happened in this last birth and what are we going to do going forward. So the first component is like look in detail at what happened the last time. So I don't just rely on a patient's report. I hear all the time, well, I delivered at 32 weeks. Oh, actually, when I look at the record, it's 36 weeks. I look at all the specifics of what was noted in the record, and then I give a woman my best guess at a diagnosis for why this happened to her. Unfortunately, with preterm births, we're often at a loss. The etiology of it, so what contributed? Was she bleeding? Was she infected? Did she break her water? Was this because of twins? And what her personal recurrence risk is. So here's an example of kind of the information that I give someone. So your diagnosis is that you came in with a 24-week spontaneous preterm birth. Spontaneous means you went into labor or broke your water. I didn't induce you because of a medical complication. As best I can tell, you broke your water first and then went into labor. PPROM is preterm premature rupture of membranes followed by labor. And importantly, I'll make note of things like I didn't think you had an infection. I didn't think this was cervical insufficiency. You weren't bleeding. And then based on actually Utah population data coming from the Utah population database, I can say if you've had one preterm birth and you are a woman living in Utah, your risk of recurrence is about 30%. And so I can outline those three components. This is important. It seems simple. Lots of women do not understand what happened and what their chances of it are happening again. When you talk to women, they haven't had this information. It's sort of human nature is to think it's all or none. So they're either told or assumed that it was a freak thing and that it's not going to happen to them again, or it's going to happen to them every single time and that this is their obstetric destiny. When in fact, it's generally somewhere in between for folks. And so people are generally surprised either way when I quote them this sort of middle risk. And part of my job is to sort of paint the spectrum of possible outcomes for them and to help parents as they sort of make that leap into parenthood again, understand what their risks might be. And that includes the fact that you may deliver before your baby can survive. You might deliver a peri-viable baby that might survive but faces steep odds of short and long-term serious morbidity or death. And you might go all the way to your due date and need an induction of labor, right? So this is the spectrum of outcomes that might happen to you, and you have about a 30% risk of it being on the early end, and if it happens again, it probably is going to happen again in about the same time period as it did before if we don't have any intervention. So that discussion, that sit down about the spectrum of outcomes and their individual risk takes some time and is a really important discussion. The second thing we go through is, okay, we've laid out for you what this leap into parenthood again might look like. Let's talk about how we might optimize the chances that you're on this better end of the spectrum. And so I'll individualize the plan for a patient. So always, in a woman who has a history of an obstetric complication, you should have an interpregnancy interval of at least 18 months. Let's make sure that you have good contraception with something like long-acting reversible contraception preferably. We look at individual risk factors. If someone is overweight or obese, we talk about weight loss as a risk reduction strategy. If someone is smoking, we talk about stopping smoking. We talk about the fact that pregnancy outcomes tend to be better when it's a planned pregnancy. For some reasons we know and some reasons we don't know. We talk about the importance of early prenatal care. One of the reasons early prenatal care is so important is it allows us time to start evidence-based interventions for preterm birth. I told you we have very little. Well, the little also consists of a medication called 17P that we start by 16 weeks ideally in pregnancy. So if someone presents very late to care, sometimes they're beyond the window where the one thing that might help them is usable. We're going to talk a little bit about preterm birth prevention with 17P because I think it's just important that everybody know what this is and what it does and why we use it. So the actual medication name is 17-alpha-hydroxyprogesterone. It's caproate. I don't know why I put acetate in there. 17-alpha-hydroxyprogesterone caproate. And you can see why we then call it 17P. It's a mouthful. So we know from randomized controlled trials that if we treat women who have a history of prior spontaneous preterm birth, they went into labor or they broke their water, and we start that medication early, ideally by 16 weeks gestation. It's a 250 milligram oil-based injection in the rear that they get once a week. So if we do that and we continue it either until they deliver or until 36 weeks gestation, it reduces the risk of recurrent spontaneous preterm birth by about a third. So it's not a miracle. Some people won't respond to it, but a third of women will go from having a third less women will go from having a preterm birth, and they will make it all the way to term. So it reduces the risk by a third of having a preterm birth. There are variations in how we define success, however, and some people will define success as going at least 2 weeks beyond where you delivered before, and in that case it has an even greater effect. So the third reduction in preterm birth is you're actually going to have a completely different pregnancy outcome than you did before. Now this medication, while it comes in a compounded form that's cost-effective, the FDA-approved form, which is now the preferred form because it has more regulations regarding purity and potency, etc., is expensive. I mean, my patients' copays can easily be $700 a month, which is tenable for almost nobody. So it goes through a pre-authorization process. Everybody is different with regard to how you figure out this process. In maternal fetal medicine, this is what we do. So that's why a lot of people send their preterm birth history patients to us, is so we could figure out this process and get them the medication, and we're happy to do that for anybody. They come in, we submit it down the prescription pipeline, which uses our home infusion pharmacy. It goes through several weeks of pre-authorization and vetting, and then finally dispensing the medication, which is typically drop shipped to their house. And sometimes it goes back and forth. It's declined. We have to put it in for Makena Care Assistance. Makena is the FDA-approved drug form name, Makena, M-A-K-E-N-A. So you need lead time. Like, this takes forever. So when someone sees me at 8 weeks, I request their prescription then, with the hope that we'll have it by 16 weeks gestation. So having them show up for pregnancy early is important. So I counsel them. When you get a positive pregnancy test, you call, and the goal is to have you in clinic by 8 weeks, a month after your positive pregnancy test. We don't have any other pharmacologic options to prevent recurrent preterm birth at this point. This is the one be-all thing. And if you think about it, I mean, some of you might be thinking, like, why does this work? It's progesterone. Like your body is flooded with progesterone when you're pregnant. Why does giving you extra progesterone of this specific type, not just any progesterone, why does this work? And I think there's some biologic data out there that suggests it sort of arrests parturition, that it makes for a quieter uterine muscle, that maybe it sort of combats inflammation. There's all these ideas, but why more sort of overwhelms the system and causes this sort of pregnancy quiescence is a bit of a mystery. But it does work in some folks. And so with that in mind, it's pretty much the best thing since sliced bread in the preterm birth world, because we have nothing else to replace it, even though people are working on other strategies. Okay, so postpartum contraceptive counseling is the third piece. So we've talked about why do you have a preterm birth, what's the chance of it happening again, what can we do to prevent it, and then third tier is postpartum contraceptive counseling. So think about this. Compared to women with term births, do you think that women with preterm birth are more likely or less likely to use contraception? I request a show of hands in the room. We have 5 people. More. How many people think women who deliver preterm are more likely to use contraception? Oh, you're pessimists. Less likely? Now you all have to vote. 5 of 5 say in the room say less likely to use contraception. I think you're biased because of the topic that we're discussing, but they are indeed less likely. And this is counterintuitive, right? The people who have an adverse pregnancy outcome, you think, okay, they're going to be more likely to use contraception so that they can have a planned, healthy pregnancy the next time around. But it's really not the case. So PRAM's data that was published in 2015, the Pregnancy Risk Assessment Monitoring System, where they send out questionnaires to a bunch of people who've had babies and ask them all sorts of things, asked people who had had a preterm birth, how likely they were to use contraception, and they asked what method they were using. And most astonishing is that women who had a recent extreme preterm birth, which they define as like less than 27 weeks gestation, that's 13 or more weeks early. Those babies are in the NICU for 3 months or more on average. That they were half as likely to use contraception. First of all, I'm astonished that only 31% of people overall were using contraception, but it's half that when they've had a prior very preterm birth. And they were also half as likely to use contraception that was highly or even moderately effective. So why is that? That's pretty astonishing data. To me, it's incredibly depressing because it means that those women are more likely to get pregnant again, and I am less likely to do what is my favorite thing in the world, which is hand them a healthy baby that they take home from the hospital after they've had a previous bad experience. They're sort of setting themselves up for obstetrical badness, as we've labeled it. So why is this? Well, if you think about it, it's not actually that surprising. So when we talk to people, like, why are you not on contraception, what's going on, there is this focus on the baby, right? It's not about me. Everything is about this tiny newborn. I'm not thinking about me. I'm not taking care of myself. I don't care what I eat. I'm not exercising. I'm barely sleeping. My whole life is this baby. So sometimes contraception goes under the rug. It's a stressful time. People will say, I just have a lot on my plate. Like, I've got this, I've got peds things, I'm going back and forth. I live in Elko. My baby's in the NICU here. I'm driving back and forth. I do not have time to talk about an IUD insertion. And I also think there's an astonishing lack of awareness regarding recurrence risk and the effect of short interpregnancy interval. We talked about some people just sort of assume this was a fluke thing. Some people have no idea that a rapid repeat pregnancy is going to be a bad thing for them. When you talk to women around the country that have had a preterm birth, I sort of pride myself on the fact that we do a good job of giving people counseling in the hospital here about what happened and why and what needs to happen and what their risks are. But we're not perfect. I know people leave the hospital, even here, where they haven't gotten all of the information that they need. And when people deliver elsewhere, the rate of receiving that information, in other words, not a high-risk center or where it wasn't a maternal fetal medicine physician available, they often leave with no idea about the answer to those key essential questions. And some of these women have had babies who are very sick, babies who have died in utero, babies who have died in the NICU, babies who have a terrible prognosis in the NICU. And often it's I want another baby. I have been through this terrible thing and I'm ready to heal by having another normal pregnancy. And so sometimes they say, I'm not on contraception on purpose because I want to get pregnant again now. In a very high-risk group of women with a history of early preterm birth who were attending a neonatal follow-up program here at the University of Utah, we did some work where we were providing that sort of postpartum birth counseling and asking women about what they were using and what was going on, and it was so eye-opening. I mean, nearly 1 in 5 women, it was almost 20% of women that we talked to who had an early preterm birth, which generally means that their babies are like 28 weeks or younger at birth, reported that they were currently sexually active, that they did not want to be pregnant, and that they were not using contraception of any kind, not even a barrier method or withdrawal. This meant that 20% of that extraordinarily high-risk population was in a category that I labeled as imminent risk of unintended pregnancy. They could get pregnant at any time and yet just did not desire a pregnancy and had not had the counseling to say, gosh, this would be a bad thing for you right now, let's wait and talk about how we can improve your outcomes. 20% imminent risk. In that randomized controlled trial done here by Dr. Torres that I referenced before, the primary outcome was looking at how many women had long-acting reversible contraception at about 3 months postpartum. So again, remember they randomized them to the usual sort of 5 a.m. Typical resident counseling for contraception. What do you want? Let's write it on a piece of paper, versus like this detailed, let's talk about the tiers of contraceptive efficacy and what's right for you. The success rate at getting people to adopt LARC, not just say they're going to do it, not just get it, but get it and retain it at 3 months postpartum, went up significantly. So it was 51% of people who got targeted counseling versus 31% of people who we just said meh. That's really important. That means just having that sit-down discussion when someone's in the hospital who's at really high risk for another adverse outcome makes a difference in how many people end up with good contraception. And while we lack follow-up data on that population to say, okay, how long did they really retain? And more importantly, did we make a difference in birth outcomes? Like if we really followed this group forward, could we say that, you know, they were less likely to have another recurrent preterm birth because of our intervention? How cool would that be? We know from other studies that LARC reduces unintended pregnancies and it promotes optimal pregnancy spacing. And both of those things, intended pregnancy and optimal pregnancy spacing, are both associated with a lower risk of preterm birth. So it's an excellent demonstration of the effect that it can have, a short conversation on birth outcomes. Counseling should ideally happen during the birth hospitalization. It's not always possible. Sometimes they're not in a place where they can get the counseling. Sometimes the person who's seeing them isn't prepared to give them the counseling from a knowledge perspective. But if you can do it, it's ideal. At least a third of women don't follow up postpartum. And women who have more risk factors, like a preterm baby, they're teens, they're in the highest risk group for another bad outcome, they are less likely to show up to your clinic, right? It's the responsible folks who are socioeconomically doing fine and who've had an uncomplicated pregnancy that show up for their IUDs. It's my teen preterm patients who are much more likely to no-show. So doing it in the hospital gives you an opportunity to get that counseling in even if they don't show up, and ideally to even have some contraception before they go home. And the other reason to do it when they're in the hospital, if you can, is that the team who delivered them is the most well-prepared to give recommendations for the next pregnancy. If someone delivers at 23 weeks, sometimes I can't tell enough from the notes. How much were they concerned about cervical insufficiency, where the cervix opens and thins prematurely without labor, versus straightforward preterm labor? If I'm the delivering doc, I can make very clear this was cervical insufficiency, or at least we're very concerned for it, and you need a stitch in your next pregnancy, not just progesterone. So that hospital team is in a unique position to accurately assess and make a plan. And because we know the retention rate for absorbing this counseling when you are, 24 hours postpartum and you now have a very preterm infant isn't incredibly high, repeating the counseling as an outpatient is also ideal. So if I see someone in the clinic, ideally they would come back to see me either for their postpartum care or for a postpartum consult so that we can review the information again. And if people are super overwhelmed, I just say, look, I know you don't know if you're going to have another baby, but if you get a twinkle in your eye, you're thinking about this, I want you to make an appointment with me and we can sit down and talk about the plan. Even if you absorb everything I've said today, which rarely happens, there might be something new and different and amazing the next time you try and get pregnant that we could do for you. So that idea of a postpartum consultation is also sort of the same as a preconception consultation. The point being, just sit down with someone who can talk to and make a plan before you embark on another parenthood journey. And of course, that interval visit is also an important opportunity for contraception, since not everybody picks something when they're in the hospital. These are just some screenshots of things that we have done to try and say, yes, we've had this conversation, and this is what I think needs to happen. So there's a section in our electronic medical record that we built called the preterm birth assessment. There's actually a best practice alert that pops up when someone's delivered preterm that says, you know, this person delivered preterm, please fill out the preterm birth assessment. And most everyone just sort of clicks ignore. And I fill it out because it's important. And what it says is, like, why did this person deliver early? What do you think their recurrence risk is, and what do you recommend for the next pregnancy? So those are sort of the sections going down, and I've selected a few things, like this woman had preterm labor and PPROM. She broke her water early. I recommend progesterone, 17P. I recommend cervical length assessment. So you can make a plan, and then you can sort of drop it into a note where it actually, this is what the patient sees in her discharge summary, is this is what you had, this is what we think the likelihood is of it happening again, and this is what we want you to do. And built into the wording, I know you can't see it very well, watch the NAT here, 18 months before considering another pregnancy, allows time for the body to heal and reduces the risk of another preterm birth. Use of highly effective contraception, IUD, or implant is encouraged. So that's a section that drops in for everybody, and then it outlines the contraceptive plan, and then my additional recommendations. So again, you don't have to be fancy about this, but for us, these tools have helped us to remember and to document. And the main thing is figure out, if you have patients who have complications, how best to do this. And if you don't have the expertise to provide the counseling, which most people don't, you say, I recognize she had a preterm birth. I've told her that she's at increased risk for this happening again. I've told her my recommendation that we use long-acting reversible contraception. And I recommend that she follow up with a maternal fetal medicine physician in order to talk about this pregnancy and make a plan for going forward. So just those elements. You don't have to say why and what the recurrence risk is, anything else. Just, I recognize this is a risk factor, and here's what we're going to do about it. So the take-home points, and then we'll go to some Q&A time. Interpregnancy interval of less than 6 months is unquestionably associated with an increased risk of pregnancy complications, including preterm birth. The optimal interpregnancy interval is over 18 months. And it's the short end of the interval that I put here, because remember, the longer end matters less. Over 18 months is what you should remember. A prenatal contraceptive plan seems to increase postpartum contraceptive uptake and LARC uptake specifically. And a postpartum birth plan that includes discussion of evidence-based risk reduction strategies and contraceptive counseling might actually reduce the risk of recurrent pregnancy complications. And we used preterm birth as our example. Okay, we're going to end there, and we can open it up to discussion. Oh, those are my kids. Sorry. Does anyone have questions or want to talk about scenarios?
There's some questions.
Okay.
Chat box. The first few questions come from Jessica. How often are we placing post-placental contraception?
Oh, I think it depends on where you are and what you do. I mean, it has come too late, I think, everywhere, but we've been doing it now at the university for a couple of years. And we have a targeted discussion with everybody when they arrive, regardless of what their circumstances are, and talk to them about the option. Because of the higher expulsion rate with immediate postpartum IUDs, for example, post-placental IUDs, some of our very reliable patients choose to come and have them placed at 4 to 6 weeks postpartum in clinic. But we make sure to especially sort of discuss it as an option and to recommend it as an option to our patients who are less likely to follow up or who have had an adverse outcome in that pregnancy. So we're placing a lot of them in women who have had a preterm birth, women who have more socioeconomic challenges, because we know from the existing literature, and you may have heard this in other talks, that if they get a post-placental IUD, they're still more likely to have a functional retained IUD at 6 months than someone who doesn't have it placed when they're in the hospital, even accounting for the expulsion rate. So some, and we should do more.
Is there access to grant devices for Nexplanon prior to discharge?
Yes, but there's a limited, Dave would probably be the one to answer this question. We have had some grant funded devices available to us and now have the ability to charge for these devices as an inpatient, which has been a long-fought battle. Not all places have grant-funded devices. In fact, most do not have them available. So figuring out that strategy of how do we get these, how do you make it as a billable item during a pregnancy, delivery, hospital admission is challenging. Some states have made it such that legally you can charge for those procedures while somebody is an inpatient. We're still working out the logistics here to make sure that that is accessible statewide, that people can have a device and have it billed separately from their delivery. But it's been a big hurdle. And so until that's available, it won't be ubiquitous across the state.
What can we do when there are cultural or language differences to increase understanding of making a contraceptive plan? Do you have any tips or tricks?
Well, I mean, I think we try and pull all of the tricks out of our bag. We try and have somebody there who's a certified interpreter and not just always a family member, and we try and have plenty of time. Trying to do this on a rushed schedule at 5 o'clock in the morning, turns out it doesn't work very well. So typically when we're trying to have these discussions, especially when there's barriers to communication, we try and set aside a time with a designated interpreter in the middle of the day, ideally with other family members, at least one present, so that more than one person can hear the discussion.
Corey has a question. He says, I've heard about a new preterm birth risk study called PREVENT, I believe. Can you provide any information about this study?
Yeah, so this is an industry-funded study that is centered at Intermountain Medical Center, and we are a participating site. It's basically saying, it's basically addressing the issue of how do we predict which first-time moms are going to go into labor early and can we prevent it? That dilemma that I sort of outlined in the talk today. So it takes all first-time mothers, it offers them a biochemical test that looks at sort of serum markers that might be indicate that they're at increased risk for delivering early. It makes a cut point that says if you're above this, we're going to say that your risk is 10 or 20%. I'm making this up. This is just how it works. And then we're going to put those people down a preterm birth prevention pathway. And that's going to mean maybe we look at their cervical length, maybe we have them see a specialist, and we treat them with 17P. That 17P drug I told you is really only for people who have had a prior risk, not for people who are in their first pregnancy and we think they might deliver early because they're having labor symptoms or anything else. So they are trialing, does 17P in a group of first-time moms who we have flagged as high risk based on biochemical markers, does that reduce their risk of going forward and having a preterm birth? So that's really the central prevention strategy in that trial, although social support and some other things are also sort of in the bundle of prevention items that they've selected. So down the road, we'll have a first trial that says, can you use 17P to prevent that first birth, which we don't know right now. Women, I think, at Intermountain and the U are going to be recruited. I think they already have 500 at various sites.
A question from Adelaide. They ask, with higher rate of complications in short interval pregnancy, such as pre-E, do you recommend advising an SI pregnancy to take ASA 81 milligrams?
An SI pregnancy, aspirin, yes, I got that part. So I think the question is, like, if you're at increased risk for preeclampsia, do we advise aspirin? And especially if one of those risk factors is that you got pregnant too soon. Yeah. Aspirin is dirt cheap. It reduces the risk modestly of recurrent preeclampsia and primary preeclampsia in people who have risk factors like obesity and diabetes. And more commonly, we're advising it for people as a risk reduction strategy. Some people have joked, and that person might be me, that maybe it should be combined with a prenatal vitamin because we're recommending it so often that it seems like it would be better bang for the buck to just combine it. But 81 milligrams of aspirin we know is absolutely safe in pregnancy, except for people who have an aspirin allergy. It's not like higher dose aspirin or ibuprofen, which we advise people against. And the trials have suggested that it reduces a little bit the risk of preeclampsia. And interestingly, in the preeclampsia trials, it also seems to suggest that women who take it, like if you give it to a bunch of first-time moms, the women who take the low-dose aspirin also seem to have a slightly lower risk of going into labor early. So we're treating people with it quite liberally. So if you have a woman with previous preeclampsia, diabetes, obesity, medical complications like chronic hypertension or lupus, who have a short interpregnancy interval. I mean, the list goes on. U.S. Preventative Services Task Force and ACOG suggest that we treat those people liberally with a recommendation for low-dose aspirin in their next pregnancy, 81 milligrams a day, starting by 12 weeks gestation is what the trials say. But if it works, it probably works because it promotes healthy placentation, and so I recommend they start it with a positive pregnancy test or even when they're contemplating pregnancy. I heart aspirin. I'm a big fan.
Jessica asks a follow-up to this. Does this need to be started before 20 weeks?
Yeah, I think the trials looked at before 12 weeks, and the only reason they looked that late is because it's really hard to recruit people for a clinical trial before that time. So the hypothesis is that it promotes a healthy placentation, and a placenta starts forming super early in pregnancy. So if someone comes to me at 20 weeks and they have this history of terrible preeclampsia, will I start the aspirin? Sure. But I am totally open with them that I have no idea if it is going to have any effect at all. But the downsides are so small, and there's no known risk, super cheap, that I have a low threshold to start it. But the best data is that earlier is better. So like I said, I counsel my patients, start it with a positive pregnancy test or even start it before. Expert opinion.
Any other questions?
Can I say one final plug?
Please.
I think a lot of times when you're trying to navigate through the world of high-risk pregnancy care and you have women who have prior pregnancy complications or seem like they're at higher risk because of things like pre-existing diabetes, what to do with them before pregnancy, what to do with them with pregnancy, and after pregnancy can be a bit of a black box to a lot of folks. Maternal fetal medicine physicians who have specialized training in high-risk pregnancy care, that is their whole job, is to be a consultant, be it by email, by phone, face-to-face consultations. Our favorite thing is to see people before they get pregnant to talk about a plan, because it allows us to do the best job at making their pregnancy outcomes better. So don't hesitate to refer your patient to come sit down, or at least talk to them about it as a possibility. Do you want to talk to somebody about this to see what your risks are, to see if we should be doing anything different? Because 9 times out of 10, when I sit down with a woman, I have some real concrete things that we can do together to change what their pregnancy outcome might be. You saw some of the things on the list. Weight loss is a huge one. Smoking cessation. General fitness. There's lots of things that we can talk about that may improve their outcomes in the next pregnancy, even if their previous pregnancy complication was perceived as relatively minor. So use us if you need us in any of those ways. We're always happy to talk by phone. I'll conclude there.
So we have a clarifying question.
Oh, okay.
So to clarify, solely short interval pregnancy is the only thing in their pregnancy history. You would recommend this woman to take early aspirin?
Oh, so if she had a history of preeclampsia or something else or other risk factors like obesity, absolutely. If it's just short interpregnancy interval and she has like previously totally healthy pregnancies, remember her most likely pregnancy outcome was nothing. Most people with short interpregnancy interval will not have a complication, right? It just increases the odds of a complication. So I wouldn't necessarily recommend low-dose aspirin for her specifically and say this is, because we have no data that would improve her outcomes specifically. But I guess my point was just I have a low threshold in general in the presence of other risk factors. So if she was morbidly obese and she had a short interpregnancy interval, it would be certainly defensible to start low-dose aspirin in her. But with no other risk factors, I guess I wouldn't champion it because it would be so unlikely to benefit her.
Thank you, Dr. Clark. Thanks, everyone, for joining us today. You'll be receiving an email from me in a few minutes, and if you do not, please feel free to email me to let me know that you were here. That's all we have.
I think if people have more questions about aspirin, since that was sort of a point of interest, the U.S. Preventative Services Task Force has a statement on aspirin and prevention of pregnancy complications that includes a long list of risk factors. So that might be something I could direct you to, and I can look it up and have you send it out to the group as sort of a follow-up item. And there's also an ACOG bulletin on preterm birth that has some key items about preterm birth prevention that could be a further resource for you if you want it as well. So we'll send both of those out. Thanks for having me as a guest.
Thank you.